All right, so next we'll be talking about early or acute management of acute decompensated heart failure. Diuretics is the mainstay. IV diuretics over PO. Essentially, PO diuretics are poorly absorbed due to venous congestion. So essentially, the underlying mechanism and why diuretics work in these patients, it decreases central venous pressure and pulmonary capillary red pressure and optimizes Starling curve mechanics. And initial treatment, IV loop diuretics like furosemide, torsemide, Bumex. If the patient's on an oral diuretic at home, you can start with 2 or 2.5 times the home dose. And there's no difference between bolus dosing versus continuous drip dosing as well. Refractory patients who are getting bolus dosing that do not put goal output, you can augment as well with metolazone 2.5 to 5 milligram or chlorothiazide 500 milligram IV administered before loop diuretics. Worsening renal function occurs in a lot of patients, around 23% or a quarter of patients being treated inpatient, and mild to moderate creatinine bumps. It's important to understand that a lot of patients come, they develop these mild or moderate creatinine bumps, and it's important that should not necessary to preclude further diuretics in these patients if they're still congested. Endpoints, you target resolution of signs or symptoms of congestion, and important to obtain daily weights as well to try to trend back to that dry weight. If patients in acute pulmonary edema, BiPAP may improve mortality and reduce need for intubation in these patients. Vasodilators, arterial venous dilation can relieve symptoms as well by decreasing afterload and pulmonary capillary wedge pressure, and can accelerate early symptom relief. And of course, patients who are already on guideline-directed medical therapy or who are not presenting with new heart failure, if they're not in cardiogenic shock or new AKI, you would continue these patients on their GDMT. You can continue the ACE, ARB, or ARNI in beta blocker during acute decompensated heart failure. However, if they were not on a beta blocker prior to the decompensated episode, do not initiate a new beta blocker in these patients. So wait until they're euvolemic and then initiate at that time. So next up, we'll talk about pre-discharge optimization in patients with heart failure, reduced DF, and preserved ejection fraction.